Assalamu alaikum wa rahmatullahi wa barakatuh. Dear colleagues, I would like to welcome you on behalf of our Saudi Hypertension Society. Yesterday was a fruitful day, and I hope that today is even so. I am honored to introduce the first speaker, Dr. Lutfi Al-Kurabi, who is the head of nephrology at King Faisal Specialist Hospital in Riyadh. He will talk about referral to hypertension expert. Please.
Assalamu alaikum. Good morning, everybody. Is my voice is clear? Or is it? Can I use this? Okay, now it's clear. Because I have to move, so maybe the port of this one is. Hello, this is better, right? Yeah. The topic that was given to me is about when to refer to an expert in the management of hypertension. accept this patient? What I'm going to do with this patient? They did almost everything. They couldn't control him. What I would have done different from them. And of course, that is a tertiary care hospital that I know it's really a very good hospital, so there's no question about it. And I don't also believe that we have enough supporting evidence for the renal denervation. And also the expert may not really have the right expert to do it. Yes, our radiologists can do it, but we are not doing it as a routine. But the second thing, I believe that we have enough medication to control everybody on hypertension. Why we have a patient sometimes is not controlled. And all the workup which was done there was negative. So am I going to repeat the workup that was done there? So I said, I think I should not accept this patient. Just tell them to look at him there. I'm not having anything extra. And then I said, let me ask the expert here. And the expert with me was Dr. Othman Al-Freh. So he said, no, you should accept this patient. Okay, so I wasn't convinced that I will add anything, honestly, and everything. He said, no, accept this patient. Let's see what's going on with him. So we accepted the patient. So the patient came to our hospital in 5 medications. Blood pressure is very, very high, 165/105. I wasn't on the surface that time, so after a week, I asked about the patient, and they said the patient is discharged on 1 medication. I said, what happened? How come a patient on 5 medication uncontrolled, and he's discharged on Amlor with a blood pressure of 135/85? And as simple as that. What happened? They said the patient was not taking any of his 5 medications. Okay, so this is, although it looks simple and we talk about it a lot, but believe me, a lot of us is missing it. We know non-adherence is a problem, but we don't really know how to discover it. How can we know whether the patient is taking the medication or not? This patient on 5, but he was not taking it. So all the workup which was done for him, although it's important, but was unnecessary. It would not have been done if somebody's really counseled this patient and talk about one of the most common cause of uncontrolled hypertension, which is really non-adherence. So we need many experts, not only for the difficult cases, but believe me, even a simple case like this does not really, you need really an expert to know that this is really a cause of uncontrolled hypertension. Now, one of the reasons we need an expert because of the blood pressure technique. I think till now, and you would agree with me that most of the hospital, the blood pressure is done in the wrong. It will be, there is no time for the patient to the rest, and everything will be done within few minutes. And you will see that, as I see in my clinic, blood pressure variability, 160/100, and if you tell them repeat it, they'll tell you it's 140/90. So it's really a big variability in the same clinic. The blood pressure, I think there was a workshop, but the best way to do it is you really have to follow the steps. That patient has to be in rest more than 5 minutes, seated, back supported, correct cuff size, and no talking, and average multiple readings of blood pressure. And this, it means that for every patient, you need 11 to 12 minutes to take the blood pressure. For every patient coming to the clinic, you need 11 to 12 minutes to take a proper measurement of the blood pressure. Okay, so the diagnosis of hypertension may not be easy as we think. Yes, sometimes it is easy if it is a very high, but sometimes it's really difficult, and you are not sure, is the patient hypertensive or not? And yes, you need to treat the blood pressure, but also you don't need to give medication unnecessary. So yes, you need somebody expert in this area. So new onset of hypertension is difficult, especially if it is a mild. A lot of physicians will be hesitant and reluctant, as well as the patient. He will be reluctant to take antihypertensive if his blood pressure is a mild. He will try to emphasize the lifestyle, but he is not going to take antihypertensive medication. White coat hypertension, mask hypertension, drug-induced. We have many drugs now. The treatment would be easy just to stop the drugs. right? One of them is non-steroidal anti-inflammatory drugs, but also the new oncology medication, anti-VEGF, tyrosine kinase. Those is one of the common medication that can cause hypertension, and the treatment will be only stopping the drug. Okay, hypertension in the elderly. So we still have physician accept a higher blood pressure in the elderly, and of course, as I mentioned, blood pressure variability. So you'd have, as an expert, he has to screen for a white coat hypertension. Now, white coat is around 20% of the hypertension. And I think all the new guidelines emphasizing about the home blood pressure monitoring or the ambulatory blood pressure monitoring. Otherwise, you will really miss. And if you will ask, I think majority of the physician is doing only a clinic blood pressure monitoring. So it's difficult to exclude the white coat hypertension without doing home or ambulatory blood pressure. Okay, those are the medications that we sometimes forget to ask the patient whether he's taking this medication or not, because these medication could be the cause of the hypertension, and you really need to go over them one by one. Is the patient taking any one of them? This could be the treatment of this patient, not really the antihypertensive medication. Just stopping the drug that could contribute to the high blood pressure. Okay, and of course, we always, as a physician, has no time to spend to discuss the non-pharmacological therapy for the hypertension, although they are very important. And you can really see that they're really as good as any antihypertensive medication. And in fact, some of them is even better than antihypertensive medications. So those we really need to spend time to discuss it with the patient as a very important measures to control the blood pressure, especially if the patient is really having a mild hypertension. This could really stop us from adding antihypertensive medication if it could be followed. Now, when the question came to me, the expert, I said, okay, let me go back and who's the expert, by the way? What do we mean by the expert? So the expert will be a person with a high knowledge or skills. So and I think, okay, then is this really the expert in hypertension or not? And this expert, it could be a family physician, it could be a general practitioner, internist, cardiologist, nephrologist, endocrinologist. So as far as he's really knows how to diagnose and manage hypertension, and he's really have many cases that he is managing, and he knows and updated about the management of hypertension, he could be an expert in this field. But the expert alone is not enough. So this expert physician, he needs other things to help him or to facilitate the management of hypertension. Ideally, there should be a hypertension clinic. You need really a multidisciplinary team to be in this clinic, so that you need to cover everything, and you need to spend the time covering everything with the patient, so that you don't miss any cause like what happened to our patient. If we really have a proper setup, the patient that I presented would not have really spent all of this in the hospital. So you need a physician, nurse, coordinator, pharmacist, dietitian, social worker, health educator. You need available blood test available, and you need maybe some of the radiological investigation. So the hypertension clinic ideally should have a physician, a nurse, a health educator, clinical pharmacist, dietitian, and of course a social worker. The expert should diagnose the hypertension appropriately. He should do the appropriate workup, educate the patient, make sure that he's adhering to the medications, dietary instruction, and of course assessment of the organ damage. And of course we have to know the compelling indication for some of the and contraindication of the antihypertensive medications. Now this is I emphasize it that this is that of course no one would be expert if there is no measurement of blood pressure at home or ambulatory blood pressure, so that we can exclude the white coat and masked hypertension, and we make sure that the patient is truly hypertensive. So this is the indication, and this was mentioned multiple times, when we should do the home blood pressure measurement and the ambulatory blood pressure. And I think the most important that this should be done on the diagnosis. I think it's very important that before you label the patient as hypertensive, you should really check the home blood pressure or ambulatory blood pressure. Okay, and one of the things that the expert should do, he should categorize the patient. As you're really aware that the new guidelines recommending the new target is below 130/80 in the high-risk patient. So you really need to know where is your patient so that you can really target or the new blood pressure target, which is in a patient with stage 1 hypertension. It will be, this is the diagnosis of stage 1 hypertension. Blood pressure is 130 to 189, and diastolic 80 to 89, and stage 2 more than 140 or more than 90. And this is the ambulatory or home blood pressure measures. And this is what is the target. The target really depends on the high cardiovascular risk. The higher the cardiovascular risk, the lower the target. So the new target is less than 130/80 in a patient with a very high cardiovascular risk, which is more than 10%, or if he has a significant risk factor, complicated diabetes or chronic kidney disease. And this is the blood pressure threshold, and I think this was discussed yesterday, so I'm not going to go over it, but this is how the blood pressure should really be managed in those patients. Now, resistant hypertension, as an expert, he should really evaluate and confirm that this is really resistant hypertension, exclude the pseudo-resistant, identify the reverse and contributing lifestyle factors, and of course discontinue the interfering of the medications. Screening for the secondary cause, some of the experts could have a facility to do the screening. You don't need to refer if you can do that. And of course, starting the pharmacological treatment and refer to the specialist in some of the rare cases. Now, so expert should know how to diagnose and manage hypertension, but at the same time, he should know when to refer to the specialist. And when I saw this word, I think we have two things. We have expert and we have specialist. Those two words, we are using them often, but I think we confuse between them. So what is the difference between an expert and specialist? In the guidelines, they always say refer to a specialist, not an expert. And the specialist, the difference between the specialist and expert is the specialist, he's really specialized in an area. For example, nephrologist, cardiologist, endocrinologist. So they really get a certificate, very specialized in this area. The expert, he doesn't need to be specialized. He doesn't need to be certified in this to be really an expert. So you will say, I am referring my patient to a specialist cardiologist, but not an expert cardiologist. The expert is something that maybe the patient can say it based from their experience or their evaluation of the physician. But the physician is really a specialist more than an expert. So we always say those patients that we need to refer to a specialist if you really need to do. Now, this is, for example, a case of 57-year-old man admitted with pneumonia, and he has basically a resistant hypertension. He has...
Sorry, Dr. Lutfi,
yeah.
Can you conclude
2 minutes?
in 2 minutes?
So this is a resistant hypertension that need to be referred. And this is the case with a high blood pressure in a patient with chronic kidney disease that also need to be referred. And this is the case in a patient with hypertension and hypokalemia. Those three cases, they need a specialist to be referred to. Okay, so one of the hypertension and hypokalemia may be to the endocrinologist, hypertension and kidney disease to endocrinologist, and resistant hypertension, it depends on the workup, but it could be a nephrologist, cardiologist, or endocrinologist. So when to refer to the specialist, malignant hypertension, resistant hypertension, suspected secondary hypertension, or others, hypertension and pregnancy. So those are the three cases that need to be, or three scenarios that need to be referred to a hypertension specialist. So what the hypertension specialists do is that if there are no workup for a secondary causes is really still there, and we need to screen in some of the patient if you really have a suspicion, and we shouldn't really miss a secondary cause. We diagnose many patients with primary hyperaldosteronism, and they were cured with just adrenalectomy. So that's really secondary is a treatable disease, not just on antihypertensive medications. Those are the common causes of a secondary. We need to focus on the common causes, which is the kidney disease, renal vascular disease, primary aldosteronism, obstructive sleep apnea. Those are really the common, and we have also common diseases. Thank you very much for your attention.